We might get started. My name is Hugh Taylor, and I am delighted to be the chair for this session on community ophthalmology, and to have Sajid Ali Suro as the co-chair and Arif Hussain as our moderator. Now, we've got a lot to get through, so I will ask the speakers to really try to keep on time. But there are lots of interesting talks and presentations, and we do want to try to hear them all. And the first one is Aslam Razak, who's talking about Pakistan Remote Area Ophthalmic Care Project, Local Ophthalmologist Networks for Best Practice.
Good afternoon, everybody. So this is a bit of a solo trip to start with, and I'm going to just give you a quick example of how we and I have kind of helped to try and run a small little remote unit in middle of Punjab, where the remote area and the ophthalmic care isn't really as good as we expect to be in the bigger cities. So starting with the just click on which one is no. Okay, yeah, it's okay. Yeah. So started a small unit, privately funded as a building wise. Aim was to and is to actually build a non-profit organization. There are lots of challenging with the district council, from the Punjab Healthcare Commission requirements, and the location. I wanted to be just outside the town where I could afford to build it in my own agriculture, father's agriculture land, and the catchment area where obviously some parts of the town and the more rural area was not really accessible, and people not able to go into the more bigger towns, surrounding towns, unless they attend a usual consent. So I started a few years ago in a small living room with a one slit lamp, and that's when I used to come and visit my mom and dad. So I graduated from here, working in the UK, come back to see mom and dad, and I'll see patients who had cataract surgery somewhere in the area and or going blind with all sorts of things. And then I feel bad when my dad tells me, oh, why did I help you and paid all that money to get you there where you are? And then so that sort of developed from that living room to this little hospital you can see on the right side eventually. So this is on a busy day. I've got like 30 odd patients waiting area inside. Then on a good day, we may have to camp outside as well. And then more recently, we had seen just over 200 patients in a day. So you might have, all of you guys who work here and seen the state of the sort of services and the theaters and everything which are in the periphery. And I haven't really put on the pictures of other local theaters and what kind of facilities are there to actually compare with. But this is kind of some of the photos of my main theater and the general theater and the surgeries, and I got some of the residents coming from UK and working with me at that place as well. So essentially the local ophthalmic care facilities are consistent of local ophthalmologists kind of the weekends. They also some DHQ and Tobatek same. And then they are surrounding quite old eye care providers who's been doing all sorts of camp areas like Gojra and Kharewal and Faisalabad. So we're in the Pir Mahal, which is the middle of Faisalabad and Multan. And the local charity camp style, a small unit which is a house which is in a village, it's been converted, and a person comes in and I'll see 100, 200 patients, and then over the weekend does 50 odd small incision cataract surgery. And then there are some slightly better quality care in the surrounding district of Tobatek Singh, but that's obviously private, doesn't provide the care to a large part of the community which cannot afford to go there. So started with the current services. There's a trained optometrist, there's two or three medical officers, and also a new consultant ophthalmologist who's a FCPS trained full-time, and then we have a visiting senior ophthalmologist coming from Lahore or over the weekend to do specialized work, and also myself coming, working 6 weeks here, 4 to 6 weeks here in Pakistan, and 4 to 6 weeks still doing my job in UK as a consultant ophthalmologist with one of my colleagues sitting here with them. So we started what wasn't really there, isn't there still in most of the periphery, is the vision screening for children. And so we went to village schools, we went to madrasas, and also diabetic retinal screening for known diabetics. And I haven't got time to present all the data, but essentially what we found out from thousands of school children screening, there's still more than 14-15% people who are undiagnosed with the unilateral amblyopic eyes or refractive errors, which never really gone and seen anything. So we're training school teachers, primary school, high school teachers to do the visual acuity test in the schools, in the class. How can they actually affect that? And also diabetic screening, just having a fundus camera and just everybody trying to see a free fundus photograph, and then working on the network so that we can actually do the grading for diabetic retinopathy and then provide them the service we can. So this is some of the pictures of the schools. My staff is visited on a weekly basis and then do the training, and those school teachers are then given the details of the hospital, so they are allowed and they are supposed to come and provide transport as well. They come and they got a free refraction, cycloplegic refraction, and those patients also who cannot afford glasses, they're given glasses as well. So the current services at this patient, at this sort of a little unit, which is a non-profit organization, starting from a simple cataract surgery, and also providing some obviously extracapsular cataract surgery, and also majority of the patients I have, my personal time is focused on when I see patients, unfortunately, who have had the surgery at a big camp, as most of you may know, locally in Dalawal, in Faisalabad, and they already unfortunately somehow had a chronic inflammation, ended up blind in one eye, and they come, and then I end up collecting every month 30 to 40 only eyes, and then I make sure I can do anything and everything to make sure I can do the other eye at the same standard as I do in UK. And I feel very satisfied when I do those cases. And then I actually, some of the local elite, which is reasonable numbers, who actually also want to then look at the services, and they want the people who normally will travel to Lahore or Islamabad or Faisalabad to go and have their private care surgery, because I have invested into having a Humphrey visual fields, glaucoma, whole workup, OCT scan, most modern OCT scan, YAG laser, selector laser type SLT machine, as well as sort of technically doing trabeculectomy tubes and MIGS is a possibility as well over there, and I'm still doing some cases. So those, and I have worked in the medical retina and uveitis along with glaucoma, and then having this availability of OCT and OCTA, which you can do equivalent of 20, 30 pound equivalent, or in rupees, how much it costs here to travel from that area. Is the cost of having that test and treatment over there, even privately, is less than your travel cost to a bigger city and bigger squint. And also have a peds ophthalmology, a GA facility where the children can have a squint surgery and all that, what they cannot afford to go into the bigger area. So these are some of the equipments I have in the clinic in the middle of nowhere, where we can do from A scan, B scan, to multi-spot laser, to IL master, to SLT combined laser, to everything. That's surgically trying to do everything we can do. Some remote area work, what I'm learning now is actually still struggling with some of the extensive local trauma. Out of hours, don't have anesthetist, and trying to do some of the complex trauma is quite difficult. Relearning to do the hard cataracts and the very mature cataracts, where most of my practice over the last few years has been doing the majority of the extracapsular phacosurgery rather than extracapsular, relearning, retraining myself to do those. And then also management of the complications. If you don't have a VR unit, then you may not be able to do the drop nuclei and deal with the infections on timely basis, whether it's your own or others' units. Luckily, so far, with the heavy investment into the theater, having a local good air filtration unit, HEPA filters, UV light, and everything, which is not really sometimes available in even bigger units. I'm not going to try and compare with. So complicated cataract surgery for only eyes, making sure we do the suitable cases for phaco, making sure we actually not trying to attempt phaco in every case. That's a lesson for me and lesson for my resident consultant ophthalmologist as well, because people are quite keen to do phaco every case, where you should not try if you think it's not in the best interest of the patient. And trying to clinically govern and having electronic health record and having record every case was quite hard on my consultant colleague locally, but he has adapted to the point, and we are hopefully being able to then all do cases in there which are suitable for that patient in the best interest of the patient. Coming back to networking of the local, we're lucky that we have a couple of ophthalmologists in the area in Tobodexing and also in Jhang, who have quite good private practice, and they quite well established, and actually trying to link with them. So we and it's lucky that in every town we send, it seems to have like-minded people who are still doing ethical practice, and they won't do things which they think they should not be doing, and referring timely manner onto the cases where it should not be messed about. So future prospects, obviously, because I've got a slightly bigger unit and involved patients, so we're now also expanding into gynae and peds, which is actually on a smaller basis, but essentially also trying to keep the same standard. So we have reduced the level of C-section in our area from 90+% to less than 40%, and that's on the basis of having a CTG and everything, so that's other fields. So in for future, within the last minute, I'm going to say I'm kind of open to cooperation with the other national charities in Pakistan and bigger sort of charitable organizations, like, I put a question mark, LRBT, other services, who may want to send their residents to work there, and with all the facilities being available, and I don't care whose name is on the top, as long as the people locally can get the service. Local training in the region, regional training can be part of the national training. Reaching out to our CSP people and college trainees here, and have been lucky to have international trainees coming along with me, my own fellow, my own registrars coming from there and coming for 3-4 weeks, and actually having the taste of doing complex cataract surgery here. And also got other colleagues who have visited, and it will probably open some doors for international sort of cooperation with trainees coming from UK here, doing in the periphery, and also maybe actually working with the bigger units in the cities like Lahore, and then going back and reciprocally we getting some trainees if we can get from here to get exposure over there. So that's what my aim is. Thank you very much for everybody.
Thank you.
Listening.
Thank you very much. Professor Hugh Taylor, he is our next speaker, and he has talked on the global trachoma updates. Thank you, Professor.
This talk, I want to talk about the work we've been doing in Australia on providing eye care to the Aboriginal and Torres Strait Islander people, the Indigenous people, and how we're trying to reach the underserved population. Now, as a starting point, Aboriginal people actually have the world's best vision. To be able to see 624, over half the men and nearly half the women can see 624 unaided, whereas in Europeans it's only 32% of men and only 8% of women. But there is this woman in that photograph, you can see the little chart under that umbrella, she is able to read 1.5 with unaided with each eye, and they have almost no myopia. But they still get presbyopia like everybody in the age of 40. Presbyopia is just a sign of growing up. And I started work with the Fred Hollows and the National Trachoma and Eye Health Program, and we were shocked to find that Aboriginal people had 10 times more blindness than other Australians. And this was due mainly to trachoma and unoperated cataract. And then almost 30 years later, I did a national Indigenous eye health survey and found that vision loss in children, Aboriginal children, was still 1/5 as common in mainstream, but in adults they still had 6 times more blindness. And this was due to cataract, uncorrected refractive error, trachoma and diabetic retinopathy. And 94% of the vision impairment was unnecessary. It was avoidable or treatable. And a third of people had never had an eye exam. So we started up a little group at the University of Melbourne that had the Aboriginal name of Minim Barang, which means tracking eyes or searching for eyes. And we started to try to do what we could to close the gap for vision and to provide equity in eye care to Aboriginal Australians. And we did a lot of stakeholder consultation across the country with Aboriginal groups, with focus groups, with other stakeholder workshops, working with the National Aboriginal Community Controlled Health Organisation that works mainly on primary care, and also with ministries and departments. And we came up with the notion that the patient journey is like a leaky pipe and there are lots of leaks. This is looking at the patient journey or the pathway of care, taking a health systems approach, starting off in the community with people living at home, and then in the general practice or primary care, maybe having a problem, being referred to see an optometrist, finally being seen, possibly being referred to an ophthalmologist, then sitting on that waiting list for who knows how long, maybe being seen, being referred to somewhere for surgery and sitting waiting for years maybe for surgery until they finally get cataract surgery or something. So we came up with what we called our roadmap to close the gap for vision that had 42 recommendations, because if you only fixed one or two leaks, the pipe was still leaking. You had to do each one of the 42 things. And this involved things with community engagement, cultural safety, primary care and specialist services, regional networks, and was clearly multi-layered. And we set up regional hubs, and there were 64 regions self-identified across the country, based around a hospital where cataract surgery could be done, and people were happy to go to have it done. And we then built regional stakeholder groups to be interested, to work together, develop the population-based needs. So if you knew your population was, say, 10,000 people, you knew you needed one full-time optometrist, 0.3 of a full-time ophthalmologist, and 8 full-time people to help manage the patient journey, nurses and opticians and coordinators and so forth. We developed the referral processes, and then also putting in the case management and the oversight of how things were run. We were putting, each year then, we put out our annual update. This was the last one when we essentially had all the recommendations committed to being fulfilled, with 88% fully completed of the intermediate steps, because some recommendations needed multiple things to actually achieve that, and made a lot of progress with that. We also had the Australian Institute of Health and Welfare, which is a government body that reports on health statistics, to come out with annual reports of eye care provision. The number of eye exams has increased more than threefold. The number of people with diabetes getting an eye exam is more than 2.5 times, nearly 3 times what it was. Cataract surgery rates have gone up. And you can see in that graph there the improvement for the Indigenous people from 2010 up to 2019, going up a bit each year, but still well below the light grey bars, which is the exam rate for non-Indigenous Australians. So a lot of good progress, but still more work to do. With trachoma, we've essentially eliminated trachoma. In 2023, the prevalence had dropped from 21% in 2008 down to 2%, and there were only 74 children in these communities that still had trachoma. Australia, 2 decades ago, said we're a developed country. We've got to do much better than just get it below 5% of children with trachoma. We've actually got to get it below 5% in every community. And some of these little communities only have 10 children, so if you have one child, you're already over 5%. So good progress there. And we've also been very successful setting up a First Nations Eye Health Alliance, which is the Aboriginal and Torres Strait Islander group who are taking the leadership and the role in trying to close the gap for vision and put vision our vision in our hands, put Aboriginal eye health into Aboriginal hands, which is, a really good way of moving it forward. So in summary, we've come a long way with Aboriginal eye health since 2012 by working together, working with this underserved, underprivileged group of people. But there's still more work to do. And the government has now got strong commitment to work with the community to develop this. We are developing this first Indigenous ownership and leadership with this First Nations Eye Health Alliance, but there's a real need to focus on the patient journey at that leaky pipe to stop each of those leaking spots. Thank you very much.
Thank you very much, Professor Hugh Taylor. I request Professor Conor Ramsden to present his talk on an enhanced referral for the cataracts, a new system for the managing.
You go now.
Thank you very much. I just want to start with, I just like to extend my thanks to Mohammed Al-Islam Razak, who's kind of brought me here today. He's been such a wonderful host. And I've been in Lahore and the surrounding areas for the last week, and it's been an incredible experience, and thank you very much. I've really enjoyed it. I'm going to speak about, I'm just going to go back a slide. So Lutra Health is a company that I have, so I have a disclosure to make in that I have an interest in the company. And these are my other interests. So, and Exeter Eye is where I work and do my private practice in Devon. And we noticed in Dr. Aslam's hospital near Pir Mahal that he has a more up-to-date OCT machine than I do in the UK. So it really is, I encourage you all to go and have a look at it. It really is an exceptional outfit. And so congratulations to him. So back to the talk. In the UK, we have a bit of a problem in that we have an aging population. So this is the population structure for Pakistan and the United Kingdom. And you can see that there's a bulge. Is this a laser pointer? Here. There's a bulge of people that we call the baby boomers who were born after the war, and they all are going to need cataract surgery. And in the UK, it's an expensive business because we're having to deliver 500,000 cataracts every year. And in many places, this is the way that it's done, is that you go to we have a system of optometrists on every high street. You start at your optometrist, they diagnose your cataract, then you go to the eye clinic and then they tell you, yes, you do have a cataract. Then you have first surgery, you come back for a post-op, you're listed for your second eye surgery, come back for your post-op, and then they send you back to your optom for your refraction. So it's a 7-point step. Now, to be fair, and each of those steps cost money. So there's £180 for a first appointment, £220 for a follow-up, and then £900 for the surgery. And the government pays for this. This is all government cataracts. And so for each cataract person, each person having bilateral cataract surgery, it's about £2,200 or lots of Pakistani rupees. Now, to be fair, so that's if you add all that up, that's pounds, it's £500 million a year spent on cataract surgery. So to be fair, in some places we've removed some of the points on the journey. So in Exeter, not everywhere, has stopped seeing patients post-op and just said, look, come back if you have a problem, and that's cut £240 off the price. Some places are doing bilateral surgery, so combining the two surgeries, so immediate sequential bilateral surgery, that can concertina it down further. But we had an idea, is what if you ask the optometrist to do this bit here, and they can do it for much cheaper and then take that out. And we did a pilot of that, and we found that in 60% of the cases, you can remove the pre-op assessment in the hospital by getting the optometrist to do that data. And then COVID happened, and we realized that people are, older people are actually quite comfortable on their phones, they're quite comfortable on the web, and it just changed the way that we all interacted with each other. And we figured out if we could set up some software at low cost that could capture even more data from the patient. And if we could capture data from the optometrist as well as the patient, we felt that we could push that 60% even higher and save £120 each time. So we built some software. And how it works is the Optom does a pre-assessment, and that could be a referring ophthalmologist or an optometrist, as we have in the UK. And then it sends a link to the patient, who get a pre-op self-assessment. So they get asked questions about whether they're on tamsulosin, whether they're claustrophobic, whether they want to have a GA, whether they have diabetes, whether they have glaucoma. These things that maybe the optometrist might not know. Well, you'd hope they'd know if they had glaucoma, but sometimes they don't. And this information is synthesized, it's joined together and shown to the surgeon it's designed by surgeons, so it's really ergonomic. So you look at it and at a flash you can say, yeah, that can go straight to theatre, that can go straight to theatre, and we sort of grade the cataracts as green or orange or red. And to our surprise and delight, that we were able to push up the rate from 60%, not requiring any preoperative assessment, to 90%. And we had a response rate of over 91%. Patients processed so far, we're about 800 done. And this data has been done by John Ellis in Scotland. And we've already saved 71,000 British pounds in about 8 months' time. 8 months to go. And it reduces the time between referral and listing for surgery to 11 days. And also the patients can see where they are on the waiting list. And if we were able to roll this out across the UK, for example, we could save the healthcare system in the UK up to £30 million a year. This is some satisfaction questionnaires that we've done with optometrists on the left. And this is Jamie Buchan, one of our optometrists who's been using it. It's overwhelmingly positive. This wasn't done by us. This was done by a third party. And the patients, for the most part, they like it as well, with a few not liking it, a couple, but that's to be expected. So what we have here is we built something for cataract referral, but what we ended up with is a system. We ended up with a system that can move data around the community. So we can connect ophthalmologists to optometrists to patients. And so we feel we can do more with this than just list cataracts directly. So we can push data from patients to from optometrist to ophthalmologist, that was set up, and patients' data to ophthalmologist. But also we can pay the optometrist with the software. The ophthalmologist can feed back to the optometrist and can send content, consent videos, lens choices, and those type of things to the patient before they even meet them. And what can we do with this is that we can use it to share care. So glaucoma patients can go wherever they like or wherever they're registered with this software, closer to home, and get pictures taken and sent to the ophthalmologist, and the ophthalmologist can feed back remotely. We can ask the patients what their outcomes were like. We can ask the optometrist or the referring ophthalmologist to send back the post-operative refractive data. So you want to know, I'm putting this 22 diopter lens in this eye. I want to get half a diopter, minus half a diopter with no SIL afterwards. Am I getting that? So you can get the post-op data. The patient doesn't have to come all the way back to you. You can get that more locally to the patient. And what I think would be useful in this environment where there's a young mobile population and a high, relatively higher rate of diabetes. Now, and people move around, people change jobs, people change city, they move country, it's a very mobile, younger people are very mobile. And their care can often fall across multiple providers, and they turn up with lots of OCTs packed into lots of folders. And so patients keep hold of their records. So it becomes a kind of patient-centered, like a digital health vault for chronic eye conditions. And these can either be reviewed by the local ophthalmologists or sent to a peripheral or a central ophthalmologist, whatever is required. So that's what we've been building over in Devon. It's called Lutra Health. And if anyone wants to contact me about that, my email address is there. And yeah, once again, thank you very much to Dr. Aslam for his hospitality and the invitation to Lahore and to the OSP.
Thank you for lighting that up. When I was asked to nominate the talks that I was giving in the middle of the year, it was before Pakistan was certified to have eliminated trachoma. So this is a global perspective of trachoma. And I think It's really important to recognise that trachoma is caused by chlamydia trachomatis. And chlamydia evolved more than 200 million years ago at the time of the dinosaurs. And every species has its own chlamydia. But chlamydia don't cause trouble in a species unless they're crowded together and sharing secretions. And in humans, we've got trachoma, including conjunctivitis and obviously genital tract infection, but guinea pigs, cats, crocodiles, birds, mice, hamsters, cattle, sheep, horses, pigs, goats, even koalas get chlamydia. And if they're crowded together, they have trouble with it. If they're not crowded together and keeping separate enough, it's not a problem. And trachoma became a problem with civilization, with hunter-gatherers 10,000 years ago, people living in small little groups of about 18 people, nobody had trachoma. But when the 8,000 years ago, when the farming settlers started, that's when people started to come together. And we had the first reports of trachoma, the epilation forceps from from 2,500 BC, the Ebers papyrus from 1500 BC in Egypt. And it was a real problem in the Nile and in the Indus and in the Mesopotamia Valley and also around the Yellow River in China. So it's been around for thousands of years. But it really came to prominence again during the Napoleonic Wars at the start of the 1800s with the French army, where a third of the soldiers developed ophthalmia within the first 2 months, and some 10% of the British army became blind. And this was also the time of the Industrial Revolution. So people were moving from farms into the crowded work settlements and slums in the Industrial Revolution. And this is a map of trachoma that goes in from the International Council of Ophthalmology in 1929. And you can see it's sort of much of the world has trachoma at that time. But with development, and these are data from Japan, you can see progressively from over a 70-year period, the rates of trachoma really were dropping as living conditions improved. And with the natural history, and this is work we did back in the 80s, animal experiments on trachoma, with a single episode of infection, people get better. It's including conjunctivitis. But if you keep repeating the episodes of infection, the disease just keeps rolling on and on and on. And to have enough inflammation sustained for long enough to give you scarring that will lead to trichitis and blindness, you need to have something like 150 or 200 episodes of infection. So little kids are being reinfected every day or every week. And then the key is really looking at facial cleanliness, because the infection is all from the infected eyes, and the eye secretions also drain through the nose. So it's keeping the kids' faces clean. And this is work, first we confirmed all this in Mexico, and then work in Tanzania showing the impact of keeping the kids' faces clean and reducing trachoma. We also helped develop the WHO simplified grading that really made it a lot more easy to get out and look at it. Before that, people had to use a slit lamp, which was not appropriate for the field teams you needed for proper control. And that graded the TF, the top left-hand one there with more than 5 follicles, 0.5 millimetre, TI, intense inflammation, the TS, the scarring, and of course the trichitis, the intern lashes. And then WHO put together the SAFE strategy, the surgery for the intern lashes, antibiotic treatment, the facial cleanliness, the F of clean faces, and environmental improvement. And then in 1997, committed to the global elimination of trachoma by the year 2020 at WHO. And the data in 2024 show that there's been a dramatic reduction. The number of people around the world affected with trachoma has reduced by something like 90%. It's gone from about 1.3 million to about 1.3 billion people worldwide to about 130 million. So a huge change. Most of the trachoma is in Africa, particularly in Ethiopia and in Nigeria are the two major problems. But Trachoma was a major problem in Pakistan in 1980. The rate in Sindh was 83%. In Northwest Frontier Province, 46%. There were some trachoma control officers, and about a third of the surgery or a quarter of the surgery being done was trichiasis surgery, of eye surgery. It was still the 5th leading cause of blindness in 2017, and in 2023, WHO knew that Pakistan still required intervention. It had 6 districts where there was a problem, and 4 people were operated on trichiasis. But then, in the middle of this year, Pakistan was declared to have eliminated blinding trachoma, which is a great joy and very satisfactory. Also, in the last 2 months, both India and Vietnam have joined the list, and so now there are 19 countries that have succeeded in eliminating trachoma, which is great to see. In Australia, we're making some progress. I mentioned in the previous talk on the work on Indigenous eye health, how we've reduced the prevalence dramatically, and we're hoping in another year the WHO will also certify Australia, although, as I mentioned in my previous talk, we have set a higher rate because we thought we were a developed country. So in summary, we will never eliminate chlamydia because it's ubiquitous, really. And trachoma occurs in areas where there's a poor hygiene, where people are crowded together with poor hygiene. And repeated episodes of infection are spread from eye to eye. Remembering that people need probably 200 episodes of infection to have enough scarring to lead to trichiasis and blindness. Facial cleanliness is the key part of the safe strategy. The surgery is the end of the result when you've got the trichiasis. Antibiotic treatment is important, but it's only a short-term measure and only eliminates 95% of the infection. Facial cleanliness is the key, and you need the environmental changes so that people have access to safe and functional washing facilities so they can keep their faces clean. Trachoma rates have dropped around the world. It should be 19 countries now because Vietnam's come in since I made this slide. And congratulations to Pakistan for eliminating trachoma and being certified to have done that by WHO. Well done, and thank you. Now, our next speaker, thank you, is Professor Mohan, who is going to talk about making invisible visible in rural population with peak vision screening system. Please join me in welcoming Mohammed Moin.
Assalamu alaikum and good afternoon, everybody. My talk is going to be on making the invisible visible with using the peak vision acuity system. I'll just go through it. So I'll just have a short video just introducing what the peak is.
Over 1 billion people live with vision loss, but don't need to. In spite of tremendous efforts to turn the tide, the number is growing. More people are held back in school, at work, at home. But how do we reach everyone? Some can't make the journey to care, or don't even know a solution exists. Many are missed through fractured health systems and don't even show up in the data. We need to work smarter to make the invisible visible. That's where PEAK comes in, powering our partners with technology to enable anyone, anywhere to be screened, analyzing data intelligently to spot shortfalls, and monitoring patient journeys to care so no one is left behind. And it means that when we succeed, we can reach everyone. unlocking the potential of millions.
PEEK is a portable eye examination kit, and we're just going to discuss the refractive errors in different age groups screened through PEEK technology. So what I showed you in the video basically was showing you that there's a huge community which exists, and there are people who have problem with their vision. They need to be screened, and it's not just screening for their vision. So PEEK Equity is an app. You can use it free for any school health worker, any other person who's there in the community, lady health workers, school health supervisors. But the main problem is connecting them to the system so that they go and they get their glasses, and from there they can become a part of the system, because they're invisible in the system, because they do not show up in the healthcare services, because they get screened initially. They know they have a problem, but they are not taken to the place where they can get solution to that. So PEEK is a tool which has got another part to it, which is the PEEK software, and that admin or software which keeps track, as Dr. Connor was discussing, a very useful tool for tracking patients and cutting down on how the visits and saving a lot of expenditure of the government. So with PEEK, what you can do is you can screen a lot of people and still get them connected through the system so they can be monitored and they can be brought for care. So this was the purpose, to map refractive errors among small age groups in Chakwal district over 1 year, and to assess the utility of PEEK tool for rapid assessment of prevalence of different disorders. Because the PEEK tool can also be used for the rapid assessment of preventable blindness, as the RAB assessment for blindness, and it's very rapid compared to doing a whole sort of a national survey of blindness. And we use a retrospective cohort study in which digital data was extracted from January 23 to December 23, and then we just categorize them into different refractive errors, which every one of us knows. The main aim was not to just give you the categories, it was just to tell you that if you screen that much, a huge load of patient, you can very easily click and get the categorization into the groups. So you can see there are various groups which come from 5 to 12 and then go up to more than 60 years of age. This is the PEEK admin, which shows you where the data is and how you can, so we were able to do nearly 1 million people screened at that area, and that screening helped us to identify that the vision impairment referred to a rural health center was about 6% of the people who were seen. So not all of the 1 million needed to go for glasses, but there are some people, about 6%, needed to be referred to rural health center, and out of them they were refracted, and 43% had refraction at a rural health center. And then there were, for non-complicated cases, non-compliance, there was 31,000. And then we have emetropes and presbyopes were excluded. So, and in total, so you can see out of the total, only 15,467 were analyzed. So that shows that the people who are picked up, but they still do not go to the service. With that, the compliance rate of the people attending the service is because sometimes they do not have transport to go, sometimes they do not have money to go, sometimes they do not know what refractive error is and what the effect of that will be when they get corrected out of that. So out of the results of 15,000 patients, we were able to show that 38% was myopia and 26% was hypermetropia. And it was interesting to see that myopia is more in children, and children going up to 13 to 18 and then 19 to 30, but hypermetropia comes up more in patients with 31 to 60, where you're probably ending up into age where you're reaching presbyopia. Patients might be latent hypermetropes, and those are the patients coming into that area. And you can see the other very important thing which we wanted to see was that the myopia We picked up myopia. We thought that myopia was the most prevalent, probably between 5 and 12, but probably it's more going on an age which is 13 to 18. And probably that also, because it's not, the graph does not show you a sequential that this patient was from this age to this age going, so it doesn't exactly tell you what is the disease prevalence, but it tells you that even people who are in 19 to 30 years of age, they were still myopic and they were not wearing glasses. Probably they had myopia before, and that was picked up at a later stage of their life. So how the peak works, so you go into the community, you will then go and screen, and then they would send it to a primary care center, a rural health center, you go for secondary hospital, and then you have a tertiary hospital. So where does your peak admin come in? Everywhere. As soon as you are screened, it goes on to the system, and there's a programmer or a data analyst which is sitting with a project manager who's controlling the area which is being used. So they will tell that these number of patients have been screened, and then they would have social mobilizers. Those will mobilize those patients and take them to the next rural health center. Either they would educate them, or they would provide them transport to go to the next level of care, so that they go there. And then the other barrier, which is to get them glasses, so you can go to them and then you can communicate with them. So you can see if they are going to a school to go screening, then the optical shop is there, or you can deliver the spectacle to them at a later stage. So this is a complete network which goes through seamlessly through an online system which works over there. So this is just a simple screening chart. There's a big issue that if you want to use Peak, you need to have Android phones, and there's a lot of investment on using Android phones. Well, that is true initially, but the total data analysis, which has shown that even if you invest on those phones, the number of screening you are able to do in a short period of time and to get them connected to care is much more with that. So the challenges which I told you before was awareness about the disease in the patients, limited resources for them, limited transportation, and limited literacy about the disease. So that is why they don't go to the places. So, but we have found that it's a cost of analysis of the screening program in district Chakwal and Laya reveal an average per patient cost about $0.93, which is translated to less than $1. And conventional data usually shows probably more or less the same amount of money being spent. So in conclusion, 5.9% had visual impairment, and myopia was the most common refractive error. And adherence to referral in rural settings was 43.9%. In order to get that adherence, a lot of effort was needed to be done. Probably if you don't have that system, that adherence to referral might be 10-20%. So that is the main effort, using the Peak technology. And this is the Peak Acuity app, which you can download on the system. And the person who's behind this is Professor Andrew Bastoris in the London School of Hygiene, and he's developed it over I think 6 or 7 years, and they've done a lot of work in Kenya and other countries in Africa and in the South Asia. And what they're going to do is rapid screening, rapid assessment, screening, triage, and referral, and data-driven optimism. And so you get the patient connected to care, as I told you before, that the main reason is to get the patient into the system. And these are the countries where Peak is working. And this is in Pakistan. They've told me that Pakistan has probably done the maximum number of screening using the Peak technology across all these countries across Pakistan. So I think we need to congratulate the CBM team sitting here, Zahid Awan and Zenith and all the other people sitting here, that they've done a tremendous job in getting these targets and getting Peak introduced in Pakistan and getting affordable eye care which can be tracked in Pakistan across different districts. And we are advocating with the government to get it incorporated into the provincial healthcare or the primary and secondary healthcare, so that it can become a standard of care for all the patients which need problems with refractive errors. Thank you.
Farooq Aman, Country Director, Fred Hollows Foundation, Pakistan. His talk is on the key lessons from the 24th week of CQI training.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. Assalamu alaikum. The topic of my talk is continuous quality improvement that foundation has been leading, and our quality concerns actually started with the establishment of this organization, the Fred Hollows Foundation. Those who are new in this room and don't know about the foundation, so Fred Hollows Foundation is Australian-based international organization, and this was founded by Professor Fred Hollows back in 1992. And in Pakistan, we have been working since 1998. This is the quote that has been taken from Professor Fred Hollows. This is a very famous saying that Professor Fred Hollows used to say, that every eye is an eye. When you are doing the surgery there, that is just as important as if you were doing eye surgery on a prime minister or a king. Most recently, WHO in its world report on vision gave two concepts, one effective cataract surgical coverage and then effective refractive error coverage. In 74th World Health Assembly endorsed global target of effective cataract surgical coverage by 30 percentage points increase by 2023. So foundation has taken the steps to be able to support our partners across the globe wherever we are present, and support them in achieving these targets. When we talk about quality, what do we mean by the quality? Quality is a comprehensive approach, and it isn't a single entity. So just take the example of a flight from point A to point B, and if you say that it was a good flight, how do you grade that, whether that was a good flight or not? Whether the flight was on time, the seating was comfortable, it was turbulence free, the quality of hospitality was good, the baggage collection was good, and the airline staff was handling the customer respectfully. So these are the areas you would go and you study, and only then you would be able to say whether the flight was a good quality from point A to point B. So similarly, we are also working on this same concept, that continuous quality improvement is a management philosophy that utilizes a continuous cycle of reviewing processes and systems with the goal of gathering data and using it to improve the overall processes. So it's all about taking the next steps. What in a recent report from WHO, the World Vision Report, talks about quality in the area of effectiveness, safety, people-centeredness, timeliness, equity of care, integration, efficiency, and environmental protection. So the quality improvement principle includes commitment from the leadership, ownership by the people and the teams, developing locally identified and locally led solutions, improvement of input structures, clearly identifying roles and responsibilities of the team members, continuously monitoring and learning for improvement, feedback and incentive mechanisms. So FHF has done its work in 3 areas concerning the quality. So we have developed frameworks and guidelines. We have created tools, and now we are doing different projects to be able to roll out all the work that has been created and done so far. So in quality, CQI, in cataract quality improvement, so it involves, because as we know that health care involves many processes and systems, as multidisciplinary teams involved in providing the care. The cataract quality improvement requires improving systems, entire systems, and few or more processes. CQI provides a framework to improve few or more processes and the entire system. So in CQI, we use IHI model for improvement, and this model actually talks about the three profound questions, which includes what are we trying to accomplish, how will we know a change is an improvement, and what change can we make that will result in improvement. So these questions can be answered in any order, and then followed by that a PDSA, plan, do, study, and act, so that at the end of the day we are sure that the change that we want to bring in is really bringing in the required changes. So this was the curriculum of the 24-week CQI training. I won't be going into its details. So there was learning sessions for our partners, hospital staff. There was e-modules there. Then there was live discussion sessions, and then followed by action period hospitals presentation and their involvement, and applying the knowledge that they have gained from this course. So in the mentoring approach, we work with our partner hospital to be able to do the initial assessment. Then there are inception workshop that are undertaken, then there are learning sessions, and then there is action period, and then CQI training. In the action learning model, each hospital is required to apply the learning, test new changes using PDSA, plan, do, study, and act, capture data and monitor progress, join monthly calls and share progress, provide monthly data. So these are the key learnings that we have drawn out of our this 24 weeks training course, that there is a better understanding of CQI principle among the participants. Then there are data-driven decisions. There are more collaboration between the teams and the stakeholders, and then there is a patient-centered quality improvements. In addition to that, practical implementation of CQI projects, building sustainability, adaptive leadership in healthcare, feedback and reflection. With this, there are a couple of priorities for us for 2025 that we would be scoping data collection approaches with the focus on quality improvement. Then obviously effective refractive error coverage and effective cataract surgical coverage protocol approaches to be developed, and piloted data ecosystem work focus both on data and quality is to be improved. Further scoping of potential of task shifting and telehealth work is on the radar for the future, and opportunities in public-private partnership to improve procurement, training, and service delivery. With this, thank you very much, everyone, for your attention.
Okay, thank you very much. It's all very good. Yes, indeed. The next presentation is from Zahid Awan, who's talking about the role of establishing optometry clinics at primary level in Pakistan. Dr. Awan.
Bismillah ar-Rahman ar-Rahim. I am Dr. Zahid Awan. By training, I am a community ophthalmologist and working with CBM International since last 1 decade. So first of all, I would like to thank Professor Muin for appreciating CBM's work and also highlighting the insights on the PEAK program, that what exactly we are doing for the poor people in Pakistan. So today it's a very simple presentation. Actually, till to date in Pakistan, we are just focusing on secondary eye care services. And we, as an NGOs, usually create models for the government to come and implement those models. So we have tried to trickle down eye care services to the primary level and emphasize that how much significant is this to work in this area. This is the roadmap of my presentations about CBM, working model, performance, and conclusion. CBM is an international development organization. Most of us might be knowing, and we work in more than 35 countries across the globe. And mostly our focus is eye health nowadays in Africa and Pakistan. Our mission is to develop an inclusive world where everybody have a right to live with the quality of life. And the mission is the same, that we understand that the disability is a consequence to which leads to the poverty. We work in Pakistan with the aim to provide comprehensive inclusive eye services and inclusion in eye health as a mandatory subject, and system strengthening approach where we work with the government. Our working model in districts is from the community to the primary level, and then secondary level and tertiary level. And why we say that role of optometry is important, because we have deployed, we found that there is a one missing link where we need to think, that Pakistan government should need to think that where is that link. When we started working in Pakistan, we all were focusing on secondary eye care services. Patient had to travel about 300 kilometers, sometimes 200 kilometers to go to the ophthalmologist or a technician to show that I have just itching and a watering. So this was a need, and also some of the surveys came in that if, for example, there is a person who is sitting in the community or at the triage level, the rural health centers, that would impact a lot. And Professor Moeen had shown that how much data has been captured at the triage level, whatever the refractive errors that has been captured, that's at the primary level. And when we talk about peak, all the areas where you see are connected with Android from community to the tertiary, including optical shops. We have given the new concept of bringing dispensing optics into district comprehensive eye care programs. And also we talk about that how we can engage the smallest administrative unit, that is called Union Council, into eye care programs. And that has been successful. We just have evaluated one of the program in Rahim Yar Khan. I will try to share the report with anyone if somebody wants to see, particularly the Professor Moeen, that how that project has achieved. And what achieved at the Union Council level, where the district eye health committees and Union Council eye health committees has been established. And that is with reference to the World Vision Report, 2019 World Vision Report. This is just, I usually show to optometrists that how they are deployed in a very, I must say that rough areas and jungles that we have employed them, and they are working for the poor people in that with the low salaries. Optometry clinics till to date at rural health centers, we have 39. It's totally supported by CBM, not CBM, I will tell you about this. And THQ, DHQ, that is 17, and tertiary level 5. Out of this 39, about 12 is supported by the government directly in the province of Sindh, where they have deployed optometrists with a governmental scale of 17, and also they have provided equipments, necessary equipment like slit lamp and ophthalmoscope, retinoscope, and the trial boxes. So this initiative has taken off very positively in one of the province, and we are expecting from Professor Moeen that how he takes this up very soon. Till to date, we have crossed 5 million target through this Android, and this is a live data available, real data available that can watch anywhere, whenever they want. Just I wanted to emphasize on this slide. When we started our program in 2018, we went through a survey to see the data, available data at one of the secondary hospital in district Chakwal, Talagang. Now Talagang is the same district, but at that time was the Tehsil. We saw that 41% of the refractive errors are catered by the ophthalmologist, because there's no optometrist, no technician, but he is the one who is doing surgery and also who is doing the refractive services, also delivering refractive services. After 1 year of bringing optometry clinics, I'm not talking about the peak, but I am talking about bringing optometry clinics only, and we surveyed again, only 1% of refractive errors are reaching to the secondary level. So this is the biggest impact we can say. And if government takes this up seriously, I think most of the primary level issues of eye care services would be dealt with. Establishing optometry clinic can reduce burden of secondary and tertiary care, and deploying optometrists at primary level can play an integral role in reducing prevalence of blindness in Pakistan. This is still the missing link, and we usually emphasize that government should take up this up. CBM is there, and CBM has extended their programs for more 3 years, and also trying to work with other international donors to support us for covering whole Pakistan, to be connected with technology sort of innovation, might be peak or other technology. So thank you very much.
Okay, thank you very much. Very interesting. The next presentation is by Junaid Faisal Wazir on the burden of blindness and visual impairment in Pakistan.
بسم الله الرحمن الرحيم اللهم رب اشرح لي صدري ويسر لي امري واحلل عقدة من لساني يفقهوا قولي. Assalamu alaikum, and a very good evening to all the colleagues and friends. So this is the building of the Pakistan Institute of Community Ophthalmology, where you have planted a small tree way back 2001, yeah, if I'm not mistaken. So it's now a bigger one, you know, when you come, and we are going to invite you. So this is my institute where I'm working and involved in the teaching and training, and I'm also part and parcel of the eye care services within the province, and also a very proud member to the National Committee for Eye Health, and also to the task force member to the WHO for developing the eye care packages, that is from 2020 to 2025, and now from 2026 to 2030. So thank you very much for giving me the opportunity for this talk, that is the burden of the blindness and the vision impairment in Pakistan. Before I start, Pakistan is situated in South Asia, where the Pakistan shares border with the India, Afghanistan, Iran, and China, strategically linking South Asia with the Middle East and the Central Asia. As of 2023 census, Pakistan population stands approximately 241.50 million, with an annual growth rate of 2.4%. Up to 64% of Pakistani population live in the rural area, and 36% live in the urban setup. So the average household is 6.4 people. The country literacy rate stands 58.9%, and only 2.4% of the GDP is spent on the education, and the 2.9% on the health. So with this low economy, Pakistan definitely faces various health challenges, including the infectious diseases, maternal and child health issues, communicable, non-communicable diseases. So the efforts are ongoing to strengthen the healthcare infrastructure and improve the access to the quality health care services nationwide. That must be with a good quality, equitable, and accessible. So the journey of the blindness prevention in Pakistan definitely starts, and we are lucky enough having a prof with us with his report on the blindness, that is the prevalence in Pakistan, which was based on the first nationwide survey, and that occurred in 1980, with a prevalence of blindness 1.78%. The National Committee for Eye Health then evolved from the ICAMP committee, and 5-year national plans were developed with the rigorous monitoring of the program activity. Now the time is passing, and the need come that how to see the impact of that national committee. So for that very reason, the impact assessed through the second national blindness survey which occur from the 2002 and 2004, where the blindness prevalence come down from 1.78% to 0.9%. So the 5-yearly plan again continue, and the time is passing on and the time for another impact assessment comes. So the objective for this assessment, that is to determine the prevalence and causes of blindness and the vision impairment in the people age group 50 years and above in the 15 districts randomly selected across 4 provinces and newly merged district, that is the FATA, formerly known as Federal Administered Tribal Area, to establish a baseline for both the cataract surgical coverage, which we are talking about. So, and another which is very important, that is the effective cataract surgical coverage. One is blindness due to cataract, and unfortunately, one is blindness due to complicated cataract surgery. So, effective cataract surgical coverage is very important. That is to determine the future service impact by 2030 and beyond, to identify the main barriers to the uptake of the cataract surgery, to ascertain the status of the vision outcome after the cataract surgery, to determine the prevalence and the diabetes in the people aged 50 years and above, to estimate the prevalence of the diabetic retinopathy and the sight-threatening diabetic retinopathy in a people with the diabetes, and also to assess the correlation between the wealth quantiles and the vision impairment in the sample population, to document the extent and difficulties in functioning in the 6th domain of disability also. So the materials and methods for this total 15 districts were randomly selected, ensuring a proper representation all provinces for the series of rapid assessment of avoidable blindness, which we call the RAB studies. The sample size was estimated based on the expected prevalence from the previous RABs in the country. Multi-stage cluster random sampling was used, and 80 clusters from each district were selected using probability proportionate to the size method. Compact segment method was used to identify the individual and the household in the community. The patient examination protocol, a standardized RAB survey protocol, was used. This involved an initial interview first, testing for the visual acuity, and detailed examination of the eye using direct and indirect ophthalmoscope to identify the causes for each level of visual acuity. Eyes were classified on the basis of the visual acuity as follow as the basis on the presenting vision. So the normal eyes with the vision can see 612. EVI, that is early vision impairment or a mild vision impairment, cannot see the 612 but can see the 618. MVI, the moderate vision impairment, cannot see 618 but can see 660. And SVI, severe vision impairment, cannot see 660 but can see 360. And the blind, that is cannot see the 360 but can see 160, light perception and no light perception. In addition, all the subjects underwent interview for the disability using the Washington Group of Questionnaire. The RAB questionnaire was made available on the ComCare data collection tool, which included all the components of the RAB 6 version. Quantitative data collection was performed using a single digital questionnaire on an Android smartphone. Analysis were performed using the RAB 6 software for the generation of the report on the crude and the age and sex adjusted prevalence, the cataract surgical coverage, cataract surgical outcomes, and the barriers to the uptake of the cataract surgery. Weighted average across the series of 15 district level, the RABs were used to estimate a single prevalence for all the 15 districts. So the results, a total of 42 1,042 subjects were examined with a response ratio of more than 90%. And also the male-female ratio was 1.056%. So if you can see, this is it's clear with this age group, and also the response from the male and female in the participation of this activity. So this is also the blindness with a very much good confidence interval. I don't want to go in detail of all these figures. It's a self-explanatory that it's fall within the confidence interval which we have calculated from our data. So the causes of the vision impairment and the blindness from this data which we extrapolated, and we got the results with a refractive error of 45%, cataract untreated is 43%, cataract surgical complication 5%, and the remaining are the diabetic retinopathy, glaucoma, and other corneal opacity, ARMD, and other. Adjusted causes for all the categories of the vision impairment, that is uncorrected refractive error, cataract untreated, cataract surgical complication, uncorrected aphakia, other corneal opacities, glaucoma, diabetic retinopathy, age-related macular degeneration, other posterior segment causes, trachomatous corneal opacities, phthisis bulbi, globe, CNS abnormalities. So this is the data which shows with the confidence interval. This again represent and the cataract surgical coverage with male and female adjustment, which also fall within this confidence interval which we have from our data analysis. So this is again the effective cataract surgical coverage which shows with a male and female adjustment, and this shows the causes of poor vision outcomes. This figure shows the barriers to the uptake of the cataract surgical coverage, and this also gives us the percentages that need not felt, fear of the surgery or the poor result, cannot afford operation, treatment denied by providers, unaware that treatment is possible, no access to the treatment, local reason. So this is the figure. Again, this is the spectacle coverage for the myopia and also for the presbyopia. 82% say no, and only 18% says that we are using glasses. And also the same is for the near vision, which is 66% and 33%. So the conclusion, there is a definitive decrease in the prevalence of the blindness, like you have mentioned in your report, Mr. Chair, way back 1980, that is, it is 1.78%. And then the second survey which we conducted way back 2002 and 2004, it reflects that the prevalence of blindness come down from 1.78% to 0.9%. So this, if we do some extrapolation with this data, because this data is also having some limitation, but this reflects that now this come down to 0.45% almost. So the cataract and the refractive errors and the diabetic retinopathy are the leading cause of the vision impairment. These findings compare well with the World Report on the Vision 2019, which also highlights these main causes of global blindness and visual impairment. The relative quality gap, that is difference between the cataract surgical coverage and effective cataract surgical coverage, remain high, indicating issues with the quality of the cataract surgery. The survey identify unawareness and poverty as a major reason for the not willing for the cataract surgical services. And the survey finding indicate that there is a gross unmet need of the spectacle coverage for both the near, that is presbyopia and the distance for the myopia. And this shows 66.7% for the presbyopic and for the myopic 82.0%. So the recommendations, that is strengthening the primary eye care by providing more rigorous refresher training to the lady health worker, because this is in our health system, this is the very strong pillar. And as my capable colleagues, Zahidawan also mentioned, that we are focusing more on the primary health care. And you have also given us a very lovely example of the leaking pipes. So if we focus on the very primary level, as what the IPAC, the Integrated People-Centered Eye Care Plan says, if we focus on the primary eye care services, that will go on, and by default, a big thing that is at the federal level, it will come up, yeah? So this is the example that we have to focus on the primary eye care. Improve the quality of the cataract surgical services by instituting a cataract monitoring program in all the hospitals by discouraging eye camps in improved settings. Enhance the scope of the social health insurance for the eye care by incorporating a provision of the near vision, that is the reading glasses, that is ready-made glasses for the vision, for the reading, and then also in the social health insurance scheme up to the specified tariff structure. Thank you very much for your patience.
Very good. I'll just make one comment. The data, the 1.8 prevalence of blindness in 1980 was the whole population,
Yeah.
where your data are for the population of 50 years and older.
So I have mentioned
And so-
that this is our limitation, yeah.
Yes, that's right. So that makes
This is
it,
limitation, yeah.
You know, and they probably form a third.
Very
we
true.
saw the pyramid.
Yeah,
you know,
very
a-
true.
A third or something of the population. So if extrapolated to the overall population, the prevalence is making
Yeah.
real progress. But it's great to have the data.
I have played a safe game. I haven't mentioned my figure in this presentation. I've just mentioned verbally that this is something like it's not the true figure. It's the limitation of this data because we are looking at 50 and above.
Thank you, Dr. Junaid. Now I request Dr. Jalil Ahmed Rajpal. His talk is on the significance of developing rural health centers at the intermediate level.
बिस्मिल्लाहिर्रहमानिर्रहीम। मेरी एक छोटी सी प्रेजेंटेशन है रूरल हेल्थ सेंटर पे ऑप्टोमीटर्स की डिप्लॉयमेंट। तो इसमें जैसे जुनैद साहब और जायद साहब ने बताया कि प्राइमरी आई केयर पे कितना काम आया, तो सिंध में हमने जो CBM के साथ और दूसरे पार्टनर के साथ फ्रेड हालोस फाउंडेशन, साइट सेवर और FHF उनके साथ जो RSC पे ऑप्टोमीटर्स डिप्लॉय किए हैं। टोटल जो हमने DHQ पे ऑप्टोमीटर्स हैं वो 4 हमने, और THQ पे 11, 28 जो हैं हमने RSCs पे। यानी कि ये वो हैं ऑप्टोमीटर्स जो हमारे पार्टनर्स ने जो प्रोजेक्ट शुरू किए और उनकी सपोर्ट के ख़त्म होने के बाद ये कुछ गवर्नमेंट्स ने हमें लिए हैं। और इनकी ये डेटा है आगे कि 2024 तक सितंबर तक कितनी हमने स्क्रीनिंग की है। ये जो प्राइमरी हेल्थ वर्कर यानी कि जो हमने BHUs और उन पे जो LHS, LHW, LHVs, मेडिकल्स ऑफिसर्स जो उनको हमने ट्रेनिंग्स दी हैं, इसमें टोटल 11 डिस्ट्रिक्ट्स हमने कवर किए हैं। और इसमें हमारे जैसे गवर्नमेंट के प्रेफरेंशियल ब्लाइंडनेस कंट्रोल प्रोग्राम था उनके थ्रू और पार्टनर्स के थ्रू ये हमने एक छोटा सा विजन स्क्रीनिंग क्लिनिक बनाई है। नेशनल हाईवे जो मोटरवे है हैदराबाद टू कराची टूल प्लाज़ा पे, उधर हम स्क्रीनिंग करते हैं ड्राइवर्स की। जो हेवी व्हीकल्स आते हैं वहाँ पर, और वहाँ मोटरवे के साथ वो नीचे उनको उतार के गाड़ी से वहाँ पर जैसे हमारी क्लिनिक पे आते हैं, तो स्क्रीनिंग के बाद जो उनको जो भी चश्मे का नंबर, ग्लासेस का नंबर, वो हम फ्री ऑफ कास्ट बना के फिर उधर देते हैं। ये हमारी अक्टूबर तक का डेटा है। और ये ऑप्टिकल सर्विस जो हमने ऑप्टिकल सर्विसेज दे रहे हैं, ये पूरे सिंध में 3 जगह पे हमने बनाई हुई हैं ऑप्टिकल सर्विसेज, और इसमें हमारे CBM और BHVI की सपोर्ट के साथ हमने किया है। ये DHQs अपग्रेड किए हैं हमने, जो कुछ हमने अपने SIUS की बजट्स के साथ किए, दूसरे ये पार्टनर्स की बजट यानी कि उनकी सपोर्ट से किया है। DHQ पूरा अपग्रेड करके देते हैं वो, उसके बाद उनकी सपोर्ट एंड होती है, उसके बाद हमने किया है। अभी लास्ट जो है हमारे शिकारपुर, कंबर और मिट्टी सांगर फ्रेड हॉलोज फाउंडेशन की सपोर्ट के साथ, मटियारी जो है हमने CBM की सपोर्ट के साथ किया है। ये हमारा जो PCB प्रोग्राम है उसके थ्रू जो हमने कैंप्स किए हैं। और ये पटीज़रा इंजेक्शन आपको पता है कि जो पूरे पाकिस्तान वाहिद हमारा गवर्नमेंट का इदारा है जो पटीज़रा इंजेक्शन फ्री ऑफ कास्ट देता है। और ये हमारे फ्यूचर्स प्लान्स हैं कुछ। हेल्थ डिपार्टमेंट गवर्नमेंट ने कमेंट किया है कि हम 140 रूरल हेल्थ सेंटर्स पे ऑप्टोमीटर्स 140 हैं, 40 पे ही हम गवर्नमेंट हमें सपोर्ट करने जा रही है। और सिंध गवर्नमेंट इसमें जो PCB प्रोग्राम के थ्रू, और एक अभी हमें नया हमने प्रोजेक्ट शुरू किया 2023 से सांगर और ठट्टा में फ्रेड हॉलोज फाउंडेशन के साथ, और उसको भी गवर्नमेंट ने कमेंट कर दिया है कि जैसे उनकी सपोर्ट एंड होगी तो वो आगे होगा। ऐसे ही स्कूल आई हेल्थ का है ब्राइन हॉर्नल फाउंडेशन के साथ, उनके साथ जैसे उनकी सपोर्ट होगी वो आगे हम कंटिन्यू करेंगे। इस तरह से साइट सेवर के साथ है। और जो मटियारी हमने शुरू किया था उसमें CBM के साथ स्टार्ट किया था, अब हम उसको पूरे सिंध में पीक जो है जहाँ भी RACs पे ऑप्टोमीटर्स हम रखेंगे वो पीक जो सॉफ्टवेयर है उसको इसके थ्रू स्क्रीनिंग करेंगे। ये कुछ हम पिक्चर से। थैंक यू।
And now I would like to introduce my co-chair, Arif Hussain, who actually has 3 presentations. The first is on the need for regional healthcare centres as advanced primary eye care centres. I'm not sure if you're going to stop between each presentation, but then...
I have dropped my third presentation. I have 2 presentations.
Okay, good too. All right.
Thank you, everybody, and I welcome everybody that you are here in this difficult hour of afternoon. In fact, both of the presentation they have some link with my colleagues' presentations, and this presentation has a strong link with the results of the RAB Dr. Junaid has mentioned. And there is one mathematical calculation through which we can find out what is the burden of unoperated cataract. It is a very simple thing, and that thing will help us what is the burden of cataracts in the community, and those cataracts, what are the visual status of those cataracts, and we will be able to know that whether they are unilateral or bilateral cataracts. And through this tool we can also see that whether how many of the eyes are affected through any of the cataract, whether it is unilateral or bilateral. This is a very simple mathematical tool, and because we are the program personnel, and this will help us, this thing will help everybody who want to establish that, as the Professor first presentation, Dr. Aslam was presenting something and about the Toba hospital. So whenever we are going to establish some clinic and we want to target how much the infrastructure and the consumable and the IULs are needed, how many surgery are to be done, and how much surgery are needed to finish the backlog. So these things, for these purposes, we need to know that how much cataracts and how much the cataract affected eye we have. So these are the 2 main prevalences which are present in our RAB survey, and because cataract is found 80% more of the cases are found in the 50 years and above. So by finding these prevalences of the 50 years and above, which is the 20% of the total population in our case, so we can easily find the number which we have for these cases, for these cataracts. And these findings are present in the RAB survey. and as an example, if we get some area, geographical area with the 1 million population, we just need to put the numbers there, which is mentioned in the yellow color. All of the finding, all of the data will automatically come in front of our eyes. So if the population is 1 million, so at the overall bilateral cataract will be around 7,000 cases, and total affected eye with the cataracts of any level of the visual acuity, they will be around 37,000. Similarly, if we apply the figure of the Pakistan, and then the figure will come out like this, and the bilateral cataract will be around 1.7 million. They are, and the total eye affected by the any level of the cataracts, they are 9 million eyes. So this is a very simple tool. I wanted to share these things so we can plan our activities and our outreach, and we can train our human resource according to this. So as this is my area where I belong, and because I think of that area many times, and my area has 64,000 of eyes affected with cataract with any level of the visual acuity. This is the far off place, very remote area of Punjab province, and this is the area where we are sitting in Lahore district. We have almost 500,000 eyes affected with any level of cataracts. So this is the key, and I wanted to all of the health professionals and the institutions and the INGOs, definitely they already know these things, but because once we know the burden, we should plan what need to be done in the case of finances, in the case of the machineries, in the case of the human resources, and definitely in the case of the community participation and referrals. Thank you very much.
Well done. That's very good, very interesting. We went one step further than that with the work for the Aboriginal people in Australia, and worked out for that number of people, we took 10,000, but 1 million is fine. How many ophthalmologists do you need to do that 7,000 operations? How many optometrists do you need to do the preliminary assessment and workup? How many orthoptists? How many nurses? How many people, secretaries to organise the booking and coordinate it, to look at that workflow? And we found for Australia, for 10,000 people, you needed 1 optometrist, 0.3 ophthalmologist, and 8.3 other people to do all the other coordination. And so to work out those human resources required based on that cataract would be a very good next step in your argument and your developments.
Yes, thank you. You're a really good point, and that will help us. Similarly, the cataract surgical rate of that particular area is also important to plan these things which you have mentioned. And the next presentation, which in fact Rajpal and Dr. Zahid, they have also mentioned these things, and what you call them the optometry clinic, and we call them as a advanced primary eye care clinics. This is the same thing. The name is only there is a difference in the name, and this name, the advanced primary eye care clinic, this is used in the IPAC, which was program given by the WHO, and that this the same concept was used, the same terminology was used in the Pakistani IPAC, which was a People Center Eye Care program. So this is the solution which we need to work now, and we need to engage the primary healthcare system, and we need to work the primary healthcare facilities. Definitely, this advanced primary eye care is to be provided at the primary healthcare facilities. So this is the concept, and most of the things that you have explained here before, and all of us we know that what is the primary healthcare, and in context to Punjab, we have very good infrastructure for the primary health care, and we already have more than 3,700 primary health care facilities. We already have more than 13,000 human resource present at the primary health care level. We already have more than 62,000 lady health workers present in the Punjab. So this is very good infrastructure already present, and the key is referral. As I think one of the presentation I was looking at, and we are referring almost 15% of the cases to the secondary level in the optometry clinic. So this referral is the key of the primary health care, and we want to develop and establish this referral change. So integration, the concept of integration is not new, and when in 1997 Vision 2020 was launched, that concept was present in that theory, and we all know about that. Okay, this is the integration which, in fact, in Pakistan, when we started our first plan, it was part of that plan also. And in that program, which started in 98, we started the curriculum development for the primary healthcare worker. We started training of the lady health workers for the eye care. So this is a very good thing that we started that thing just after the launch of the Vision 2020. So this primary eye care is the thing which we need to now adopt for the communities, which we are almost 60% of the population lives in the rural areas. So for that area, we think that this is the right thing, and for that purpose, we have a very good infrastructure of rural health center in Punjab. We have more than 316 RSC present. So, and these RSC are already working in they are the central point of the vertical health system. So it is very easy to channelize them and use them for our advanced primary eye care. So this is the different task and responsibility which can be performed at the advanced primary eye care, and these tasks are already defined and written in IPAC, Integrated People Center Eye Care Program. These tasks are not new things, and apart from the last one, which have some debates, everybody agrees on these things. And what we have done in Punjab, and in the bottom there is a table which was I took the picture of the IPAC Punjab, and we already approved 79 rural health center as a APAC. So, and the cost is already written there, and these instruments are already mentioned there, and it will cost 4 million total 4 million for the equipment. And we have advertised, and we have started advocacy to the health department about this. And this is the new thing, and because whenever there's a new thing, we need to be extra conscious for the implementation issues. So refresher for the optometrist, monitoring and training and supervision by the doctors, these are the important things which we need to do. And in Punjab, we have 6 districts where we have this private public partnership, and we have established the advanced primary eye care centers, and you can clearly see that overall there was 56% of the cases who were only needed refraction, and out of the total cases 4% of them they were referred and they needed some advice by the ophthalmologist, and overall there was 20 patients per day. And it is very, very good that where the RSC there was not a single torch, there was no eye patient coming. But this is the data of this year, this 10th month of the 2014, and we are having 20 patients per day. So this is the final recommendation and suggestions, and for the advocacy purposes, that whatever there are the issues, because there are the problem with the post at the RSC, There are issues when we have posted the optometrists at the rural health center. There are administrative issues. So these are the things which need to be sought out and spelled out properly in the documents. And similarly, the district authorities and the concerned ophthalmologist and the definitely monitoring body like we are looking the Punjab area. So their involvement and supervision and monitoring and very important. So this is the most important thing now, that we should need to physically integrate the primary eye care into primary health care. Thank you very much.
Very good, thank you. I'm not sure if there are any questions or comments that people would like to make in the room. There have been a series of really interesting presentations showing some really great groundwork. Well, in the lack of any further interaction like that, I would like to thank each of the speakers for a very interesting and successful session. There's a lot of good work that's being done. All needs to be built and developed and fully implemented. So the glass is totally full, but you're doing a great job. Thank you all very much.
May I request all the participants to have a group photo, please?